A very good evening, ladies and gentlemen. We are delighted to invite you all to an enlightening webinar organized by the Indian Society for Prenatal Diagnosis and Therapy, acronym ISPAT, in collaboration with Strand Life Sciences. Today, we will delve into the important topic of spinal muscular atrophy on the occasion of Spinal Muscular Atrophy Awareness Month. During this webinar, we will explore the crucial aspects of spinal muscular atrophy with expert speakers who will cover various topics related to SMA. Our aim is to enhance understanding and awareness of this condition, both from a clinical perspective and in terms of management of challenges. I am honored to introduce the esteemed ISPAT office bearers. Firstly, I would like to introduce the President of ISPAT, Dr. Saurabh Dani. He is the Consultant Obstetrics and Gynecology. He is a visiting consultant at Ankur Hospital, Kandivali West, and he is also the co-founder of Health, a center for preventive medicine. His experience includes him being the president of ISPAT for 2023 and 25. He is the treasurer at Bombay Nursing Home Association. He is the coordinator at MCGM Newborn Screening Program. He has been the joint secretary at Kandivali Medical Association. And in the past, he has been the president and advisor for the Association of Fellow Gynecologists. His educational background includes FCPS of MID and Gynecology, University of Mumbai, MBBS from Krishna Institute of Medical Sciences, and DGO from Nauroji Wadia Maternity Hospital. A very good evening, sir. I request you to say a few words to the audience.
Good evening, everybody, and thank you for the lovely introduction. And thank you, Dr. Veronica, for suggesting this topic along with Strand. The purpose to earmark any days or months is generally to see that a lot of people or organizations do concentrated efforts during that period, so that which helps in creating awareness on the subject. Now, SMA has seen a lot of changes recently. It's not just a rare disease anymore. Now it's a treatable rare disease. So NBS for SMA is now part of the recommended universal screening panel, that is the RUS panel, since 2018. So today we have the following avenues available for SMA. We have newborn screening, we have a confirmatory test which is available, we have a treatment, although expensive, and prenatal diagnosis. So with this webinar, I hope we are able to increase awareness on SMA and stimulate everyone's minds and discuss and talk more about SMA and how to prevent it and cure it. Thank you very much. Over to you.
Thank you so much, sir. Now I would like to introduce the Secretary of ISPAT, Dr. Manjeet Mehta. Dr. Manjeet is a consultant in reproductive genetics. She is the director of Lifinity Genomics Lab and Research Center in Mumbai. She is presently the Honorary Secretary General for ISPAT. Her experience includes medical geneticist of national repute, having more than 3 decades of experience in human genetics. She was involved with research in the Indian Council of Medical Research, the apex body in India for biomedical research. She has expertise in assessment of recurrent abortions, infertility, pediatric syndrome diagnosis, and leukemias. She's had training in advanced genomic technologies from Center of Advanced Genomics from Yale, USA. She has had several publications to her credit in reputed journals and book chapters. Dr. Mehta's educational background includes MSc in genetics from the University of Mumbai. She completed her PhD in human genetics in 2001 from Jesloke Hospital and Medical Research Center. She did her postdoctoral fellow in medical genetics from Toronto, Canada, and her postdoctoral fellowship in reproductive genetics from UCL London. A very good evening, ma'am. Thank you so much for joining us. And I request Dr. Manjeet to tell us a little more about the ISPAT Society.
Good evening, everybody. Thank you for the kind introduction. On behalf of ISPAT, I take this opportunity to welcome you all to this webinar. As we are all aware, this month being the SMA Awareness Month, ISPAT has taken up this activity of conducting a webinar, whereas, wherein people will come to know more about the condition. ISPAT is a society of like-minded people, including obstetricians, fetal medicine specialists, pediatricians, geneticists, and neonatologists. We got together more than 3 decades back in the year 1989, and we are trying to propagate the academics as far as prenatal diagnosis and therapy are concerned. Today, we have grown in strength. We have a lot of academic activities. We conduct workshops, and we try to put down some guidelines and approach authoritative bodies with the same. It would be good if you all went and checked out our website, ispat.org.in, which lists all our activities, and this is one of the academic activities that we are conducting under ISPAT. So once again, thank you all for taking out the time and coming and attending this webinar, and back to you, Jay.
Thank you so much, ma'am. Now I would like to introduce the convener for today's webinar, Dr. Veronica Arora. Dr. Veronica is a consultant clinical geneticist and assistant professor at the Institute of Medical Genetics and Genomics from Sir Gangaram Hospital in New Delhi. She is a member at the Association of Obstetrics and Gynecology of Delhi, Bengal Obstetrician and Gynecological Society West Bengal, Society of Fetal Medicine, Indian Society of Inborn Errors of Metabolism, Indian Academy of Medical Genetics, Indian Society of Inborn Errors of Metabolism, and she has had several research publications in national and international journals to her name. Dr. Veronica has done her MBBS, MS, and DNB in obstetrics and gynecology. She has also done her DNB in medical genetics, and she's been a gold medalist. Wow. Good evening, Dr. Veronica. Thank you so much for being here. And I request you to take the program forward.
Thank you so much for the kind introduction. And I thank ISPAT and all of you for being a part of this webinar. And without further ado, I would like to introduce our esteemed chairpersons for the talk that is on the clinical, diagnostic, and management aspect of SMA. So the first chairperson we have is Dr. Akhila Vasudev, who's a professor and unit chief in the Department of Obstetric and Gynecology and a chief consultant at the Division of Fetal Medicine in Kasturba Medical College, Manipal, Udupi District, Karnataka. She has vast experience and has received DBT Crest Award 2011-12 and authored more than 50 index publication in peer-reviewed journal. She has trained in fetal medicine at Center of Fetal Care, Queen Charlotte Hospital, Imperial College, and she's been involved in undergraduate as well as postgraduate teaching. And for her educational background, she's done MBBS, MD for Kasturba Medical College, Manipal. Welcome, ma'am. Our second esteemed chairperson for today is Dr. Varsha. Can I please have ma'am's CV?
Namaste.
So ma'am is the director at Baste Maternity Hospital and Pushpa Fertility Center, and she's a practicing gynecologist and infertility specialist. Her experience includes the first ICSI PGD baby in North Maharashtra, and she was the past president of OBGY Society Nasik, chairperson at Foxy, prestigious Dr. Anandbai Joshi Awardee, and she has many other awards like the Foxy Champions of Foxy Award, Foxy Excellence Award, and organized many national and international conferences. She is also an MBBS, MD, Gynae and Gynecology in IVF. So we welcome you, ma'am, and it's a pleasure having both of you.
Thank you.
I request you to now start the webinar with our first talk, which is by Dr. Kaushik sir.
Thank you so much. Thank you, esteemed guest panel and the audience and all the organizers of ISPAT, Dr. Dani sir, Dr. Manjit Mehta, Dr. Veronica is a convener. I'm really impressed by the work you all are doing, because when I've gone through all the what you all doing, it is really important to have such perinatal diagnostic tools, and there are so many dreaded diseases to be diagnosed before the baby is born, and also the management after it is born. And it is really disheartening to see these babies with muscular dystrophies, different types of dystrophies. And today's topic is this SMK, SMD, spinal muscular dystrophy, and none another Dr. Kaushik Mandal is going to talk on it. So may I introduce Dr. Kaushik Mandal. He is a pediatrician and medical geneticist, additional professor, Department of Medical Genetics from Lucknow. Previous experience at LHMC New Delhi and CMC Vellore. Lab diagnostic skills, Sanger sequencing MLPA, authored over 80 publication, 5 chapters, 2 inclusions in London dysmorphology database. Clinical expertise are dysmorphology diagnosis, pediatric genetic disorders, genetic counseling, antenatal diagnosis by sonography, amniocentesis, CBS sampling, etc. And he is a MD pediatrics, DM in medical genetics. So over to you, Dr. Kaushik Mandal, who is going to talk on spinal muscular dystrophy, which is really dreaded to diagnose and to treat also, and rehabilitation is also very important. So over to you, Dr. Kaushik Mandal.
Thank you, ma'am, for the kind introduction. Spinal muscular atrophy is a genetic disorder, and we'll be talking about this disorder. I'll be giving an overview. Then during the panel discussion, we'll hear in details the pros and cons of various testing, the various treatment available. First of all, we should know how to diagnose it, how our eyes will see these children, how we pick up, how we counsel the families. I have nothing to disclose. I have no financial relationship either of the sponsors or with the drug companies who are manufacturing the drug. I have no conflict of interest. So the commonest or probably the most frequent presentation which we see is a child with hypotonia or a floppy infant. The diagnosis will be first, which comes in our mind, is spinal muscular atrophy. The second will be Pompe disease, which is again a lysosomal storage disorder and also a glycogen storage disease. For these two, treatment are available, and we should not miss both the conditions. Whether we get the medicine, whether we do not get the medicine for the child is a secondary thing, but we cannot miss it. And both of them are autosomal recessive conditions, and we have prenatal testing available. So we should not miss these two diagnoses. They look very similar in an infant or a young infant with this diagnosis. There are other common conditions which will mimic spinal muscular atrophy, or the child will present with hypotonia, like central nervous system abnormalities, some chromosomal anomalies, Prader-Willi syndrome. They present with hypotonia. These children are difficult to feed, and later on they gain weight. Paroxysmal vaginosis disorder, congenital myopathies, congenital muscular dystrophies, like this. So this is a family which I have tried to show you, that one child is affected and parents are generally carriers. So I've tried to show this where the motor neuron is. We all know as doctors that this is the cross section of a spinal cord. This is the motor neuron, and this is the sensory neuron. So whenever the motor neuron is affected, the nerve cell or the body dies because of a protein, a lack of protein, which is called survival motor neuron protein, which is produced by SMN1. SMN gene has two copies, the telomeric and the centromeric copies. One of the gene, which both are very similar. SMN1 produces the bulk of the protein. SMN2 produces very small amount of residual protein, which is being formed by SMN2. So when there is deletion of exon 7 or exon 7 and 8, it causes SMN1. And it should be present in both the alleles. That is called homozygous. So a homozygous deletion of exon 7 and 8 of SMN1 gene produces SMA. Because the protein is not produced, we have to remember that it is very likened to a motor neuron disease. You know this person, this is Stephen Hawking, who has motor neuron disease, who does not have SMA. But I have put it deliberately because people might be able to make the difference or might be able to correlate how the disease is. So when the motor nerve is non-functioning, the muscle cannot contract. They are mentally alert, brilliant people uh, who cannot move their limbs, or maybe has difficulty in speaking, or they have respiratory difficulties because they cannot have a good cough reflex. So this is motor neuron disease. It has nothing to do with SMA, but SMA is absolutely very similar to this. This is Sharmishta. Sharmishta is a very famous writer of the Northeast, and she has SMA type 2. See how both of them, I've just put these two pictures together just to tell that they are brilliant people, and like just like motor neuron disease, just like Stephen Hawking, there are children or adults with SMA who cannot move their limbs, who cannot move about, has problems with their respiration, and they have the same problem with the motor nerve. So in some drugs which are being used, will be discussed later on, how that SMN2 copy number influences the disease status, how SMN1, SMN2, SMN3 differs because of the SMN2 copies we'll be discussing. So SMN2 essentially is a copy of SMN1, which differs in very small nucleotide changes, but it produces a very small amount of protein. So if a person does not have SMN1 and also SMN2 homozygously, they are deleted, it is incompatible with life. They do not survive. So these, I have already discussed that there are so many differential diagnoses of a child with hypotonia less than 6 months, that it can be due to congenital myasthenia, it can be due to congenital muscular dystrophy, myotonic dystrophy type 1, and so on and so forth. So we won't be going in details about this. In the later childhood, again, there are so many other disorders, some genetic, some non-genetic, like Guillain-Barré syndrome, which might mimic SMA. In adulthood, as I have told you, amyotrophic lateral sclerosis, that is motor neuron disease, which Stephen Hawking have, they mimic SMA. So there are so many other mimickers of SMA, so you have to be very, very cautious. And many of them might not be genetic as well, as some might have many genes involved in the disorder. But SMA is a clear-cut diagnosis, and SMA is a very common diagnosis. So we are not supposed to miss it. So according to the age of onset and what milestones those children achieve, SMA has been divided into various forms, like SMA type 0, SMA type 1, 2, 3, and 4. But essentially, we divide it into 1, 2, and 3. SMA type 0, it is prenatal onset. That means the baby is born with so much hypotonia that they can be easily recognized at birth, and they have very severe weakness. SMA type 1 is the commonest form, which we see as pediatricians. They present in less than 6 months, and median survival is around 8 to 10 months. They generally do not survive. So they do not survive beyond their infancy. Some head control they might achieve, but they never achieve sitting without support. So with support, some sitting they might achieve, but without support, they will not sit. Type 2, they will sit when placed in sitting position, and most of them will be alive till adulthood, because and with support they will be, see, I have put one and written without support, with supportive care only. That means without disease modifying agent, this is what they achieve generally. So around 70% of type 2 will be living into their adulthood, but they have severe scoliosis because their spine cannot take the burden of the body because of hypotonia.
Hello.
They have severe scoliosis, and they eventually develop respiratory problems. Many of them require BiPAP machine at home. SMA type 3, they achieve walking, they achieve independent ambulation, and in the infancy, they are almost not found, though mother and father can find that those children have some amount of hypotonia, maybe slightly delayed in motor. And remember that all these children have very good cognition. So a parent cannot recognize SMA type 3 almost in the infancy. With just they might be seeing that the child has mild motor delay, which they will try to find it that it might be similar to other family members as well. Type 4, again, it is very much like type 3. They present in adulthood and their lifespan is almost near normal. So type 3 and type 4, the lifespan is normal, but they might lose some milestones. They might have other postural problems as well. So you see, this is type 1. The baby can only move limbs in the plane of the bed or plane where she is lying. Almost she cannot take out the hands against gravity. But see that this baby is actually did well. There are other sounds coming. So this is type 1. She has a good nutrition, so she survived with to get her therapies. So after therapy, she could sit. Otherwise, she would not have sat. So this is the same baby who could sit after therapy. After we have just finished the loading, she could sit. This is a child with type 2. You can see that when he is made to sit, he can sit. He has achieved sitting. So this is a child with type 2, and you can see they eventually develop small amount of contractures as well, and they have hypotonia. So this is a child who is type 2. So if somebody knows Bangla, can make out that he is telling, why are you making me stand? Won't I fall off? So he is a child with type 2, but see, he has achieved some amount of standing and walking with therapy. This is a child who has clear-cut type 3. She achieved ambulation but has hypotonia. So this is a child with type 3. So all these children are on therapy with us. They are doing fairly well. So SMA has some fancy names, and pediatricians would like to remember it once more. SMA type 1 is also called Widening-Hoffmann disease. SMA type 2 is called Dubois disease. Present classification of type 3 was named as Kugelberg-Wallender's disease, because at that time people used to think that they might be very different disorders, but they are the same disorder. And according to the SMN2 number copies, they differ. SMA essentially is a autosomal recessive condition. That means both alleles should be having the mutation, and parents would be carriers. The geneticists know that in a small percentage, one of the parent might not be carrier, where both the alleles are in the same copy, or both the normal copies of SMN1 is on one allele, one of the parents. It is present in 5% of the carriers, which is very, very rare. Otherwise, both the parents would be carriers. Carriers have no symptoms, and there may be one or more children affected in the same family, in the same siblings. So they have unaffected parents. Males and females are affected equally, and probably no, not for SMA, because it is due to chance marriage of two carriers, and sometimes in autosomal recessive rare conditions, there can be consanguinity. So the population frequency is quite high. As you can see, 1 in 40 to 60 in Indian subcontinent. And we have two papers, one from Gangaram and one from our HGPGI group. And the estimated incidence varies with population, but you can see that around 1 in 50 to 1 in 100, it is there all over the world. So the carrier frequency is very, very high. And as I have told that it is an autosomal recessive condition, so it is very, very important that we diagnose this condition. So today's topic is diagnosis, how we diagnose. So most of them are due to deletion duplication of SMN1 gene, exon 7 or exon 7 and 8 together. And SMN2 is another gene which we will see that how with the SMN2 copy number, it differs, the presentation differs. So sequencing detects 2 to 5% of individuals who are compound heterozygous, as I have told you, that with one copy deleted or heterozygous deletion of SMN1, you can find SMA in a very small percentage of children, where you have to again sequence the SMN1 gene, because there might be a point mutation in there, but that is very, very rare. So this is the diagnostic algorithm. that if you suspect SMA, you look for SMN1 deletion. It is done by MLP or QFPCR. We use MLP. I will tell you the technique of MLP, what we use. Then we see for SMN1 copy and also SMN2 copy. Then if it is 0 copy of SMN1, that means a homozygous deletion, you confirm SMA. If there is 1 copy, but still you suspect SMA, then you do SMN1 sequencing, which is rare. We rarely do it. And you find a mutation, you confirm SMA. SMN2, if there is more than 2 copies, then it will be other disorders. Then you see the SMN2 copies, and it predicts the severity of SMA. If SMN2 copies are more, then the manifestation is less severe. It suffices for production of some protein. So these are the machines which you require. One PCR machine and one sequence type electrophoresis so that you can run. So MLP is a very versatile technique. It can be used for various methods, and we were the first to publish article on MLPA from our country in 2009, and then it has been used for various other disorders, and now we use for Duchenne muscular dystrophy and SMA. These are common molecular testing done for SMA and Duchenne muscular dystrophy. In MLPA, we have a probe pair where there are 2 hybridization sequences, and each probe pair binds to a specific area of the genome. For SMA, we only require exon 7 and exon 8 of SMN1 and also for SMN2. So we'll see the copy number of SMN2 with this and also the SMN1. So these probe pairs will bind, and different probe pairs are used for different targets. Suppose this is SMN1 and this is SMN2. So we will have different probe pairs for target A and target B for SMN1 and SMN2. So there will be 2 copies. So each copies it will bind. So first there will be denaturation. What I have shown that the double-stranded DNA becomes single-stranded. The probe pair goes and binds. So this binding is called hybridization. This is the exact complementary to the target what we want. After hybridization, there is ligation. So the probe pairs, the forward and the reverse get ligated. So there is no gap. I have shown this gap, but there is actually no gap. And here is one ligase. This is the stuffer sequence, which differs for each target, so that the product you get is actually PCR amplification of these probe pairs, and different probe pairs will be having different lengths after PCR. So do you have multiple copies of the same probe pairs for in your final analysis? You run in a capillary and you see these peaks according to their molecular weight, according to the base pair. So the larger or the heavier will segregate later on, and the lighter will segregate early, and according to their base pair, we'll find out which peak is for what. Then we use a software to find out whether there is homozygous deletion. Here you can see homozygous deletion of SMN1, and there is some heterozygous duplication of SMN2, which gives the idea. So this is how it looks, the peaks looks like, heterozygous like, and when you see the output, you see that in homozygous deletion, the ratio is 0, SMN1 exon 7, SMN1 exon 8. So this is homozygous deletion. And SMN2, if it had been here, that means there are 2 copies. Probe ratio 1 means it is 2 copies. So it is around 3 or 4. So there are 3 or 4 copies of SMN2, which makes the diagnosis of probably SMA type 2 or SMA type 3. So we'll tell you about this. When you do in the parents, you can see the parents are heterozygous. So the probe ratio will be around 0.5. That means one allele has a deletion, the other alleles do not have a deletion. So each parent will look like this. The output will look like this, heterozygous deletion in parents, right? So whenever a baby is there, you do in the baby. If the baby is not there, you can just do the parents and find out and do. So this is, suppose somebody has come, this is a hypothetical, somebody has come at around 12 weeks, and you can do a prenatal just by screening the parents. If the baby is not alive, and you have known that the baby had hypotonia and something like SMA, if the baby is alive, you have to do in the baby, right? So according to clinical phenotype and SMN2 copies, as I have told you, so most SMA type 1 will only have one SMN2 copy. SMN type 2 will have more copies, but many of them will have only one SMN2 copy. And according to their severity. So less severities, then the number of SMN2 increases, right? So this has been proven beyond doubt. So SMN2 suffices for making some protein. So this is a scenario where we find a child with hypotonia and we try to find where he fits in or where she fits in, what type of SMA the baby has, whether it is SMA or it is not SMA, and whether we can provide some therapy, whether we can provide prenatal testing, whether we provide for genetic counseling. But many other developed countries does a newborn screening just from blood spot, but we have to. So you know that what are the criteria of newborn screening. So screening commission started in 2018 and it started with USA because they can provide therapy. So they thought it is good that we start doing it as a newborn screening. So there are criteria where we should and where we should not do newborn screening. So we'll deal with all these areas while we go for panel discussion and what are the ethical issues over here in newborn screening. So, but therapies are there and we'll again be discussing therapies in the panel discussions. Because of therapies, this is an important area. So there are three probably hallmarks of this disease. One, the carrier frequency is very high and we should recognize this. Number two, the testing is available now easily all over the country. Various labs, private and government, are doing this test. So we should not miss, we should be able to do prenatal testing. And therapies have come up in the pipeline and also they have been marketed. Various therapies are there. So this is the genetic disorders which are amenable to therapy. At least some treatment could be given. And for them which we do not have therapy, as I have told you, we do CVS at around 11 to 12 weeks for SMA, but we have to prove it either in the parents, that parents are carriers, where or the proband, the child had SMA, that is homozygous deletion molecularly. So thank you so much. Thanks the organizers for giving me this opportunity, funding agencies who have shown us the light of treatment for SMA, my patients, my colleagues and institute. So this is my this is Brijesh who does MLPA for us. This is Shashank who does Sanger for us, and my friends who rides motorcycles with me. Thank you so much.
Thank you so much, Dr. Mandal. That was a very crisp and very fantastic, concise lecture, which gives almost all information which we need to know. So just a few comments or queries from the side of a common obstetrician. Although I'm a fetal medicine specialist, we need to first of all educate common obstetricians on how to take history. We teach undergraduates, postgraduates how to take past obstetric history, isn't it? So when to suspect this problem? So that's, I think, very important. That's one thing that we need to know. Can you just tell us a little more about that?
It is internet.
One thing probably I missed is that while a pregnant woman comes very early in pregnancy or comes for a preconceptional counseling, we always tell about beta thalassemia screening. All obstetrician does. Nowadays, we tell about SMA screening as well. Beta thalassemia screening would be cheaper and indirect. For SMA screening, we have to do MLPA. But for all pregnant women who comes for a preconceptional counseling, whether the family has a history of a child death or whether the previous child had hypotonia or not, irrespective of that, we ask for screening for SMA in one of the couple, one of the spouses. If one spouse is found to be carrier, the other spouse is being screened. For irrespective of what is their previous experience of reproduction, right? So this is one thing that we do a screening for SMA, at least at tertiary care hospitals, they should be doing, and they should be trying to put this forward to every patient who comes to them. The other is sometimes it is told that less fetal movement or due to less fetal movement, there might be polyhydramnios, but we are not very sure whether it holds true. And there are so many other causes of decreased fetal movement and polyhydramnios, not just SMA.
Yes,
But
yes. Definitely, there are so many other causes. So we can only say that this is one of the most common cause of that. That's all we can say, isn't it, Dr. Mandal? We can't really come to a diagnosis based on your movements.
Yes. So if it is really found that there is less fetal movement, but by that time they recognize that there is less movement, probably the time is less, but along with other tests, probably we should also test for SMA and also the parents for SMA carrier screening.
And one more thing from the fetal medicine obstetrician's perspective, I think we all should understand the complexity of genetics here. It is not so simple that you just do one amnio, send one CMA, send one exome sequence. They are not at all the ideal tests for SMA, isn't it? I think that message, if it comes from you to the audience, it is very good, Dr. Mandal.
Yes, every genetic disorder has a different perspective, and not everything can be diagnosed by exome sequencing. That is one thing everybody should understand. We should all understand. People think that there is a stop-go test, NGS or exome or something like that. But for SMA, it is a very different test, and you really have to suspect the disorder in the family, or maybe when they tell that our previous child was hypotonic, there was pooling of feed and he could not feed well, we should, the obstetrician always start thinking that it might be SMA. So it is not a couple exome which they should send. It is a couple MLPA or other tests to rule out SMA carrier in the couple, and not just couple exome for hypotonia, and just not karyotype for hypotonia.
Just bringing out these points as chairperson for the audience to understand that it is not so simple that just do an amnio, send CMAs and exome. It is not that simple. Each genetic disease has its own test. So therefore, we all should learn how to take help from experts like you. So that is the second point. And I think, as you rightly said, not all cases are for MTP. That's one more point. That because there are therapies available, and you showed very beautiful examples. It is so touching to see that you're treating them and they're improving. It is, I think, really wonderful. It is very rewarding, I think, Dr. Mandal. Thank you so much.
Thank you, ma'am.
Thank you, organizers, for giving me the opportunity to be the chairperson for this very, very important topic of SMA. And I congratulate Dr. Kaushik Mandal, sir, for your really precise presentation, giving the causes, the longevity, the treatment modality, the diagnostic modality, and everything was covered in your talk. Thank you so much. Thank you, Dr. Dani, sir, Dr. Veronica, and Dr. Manjit, for giving me the opportunity to be chairperson along with Dr. Akhila. And I can see Dr. Nalendra Malhotra, sir, also. Namaste, sir. Good evening. Thank you so much.
Thank you, ma'am. Thank you so much for joining us today and giving your valuable input. And thank you, sir, for an excellent talk like always. So we have lots of questions, but most of them are going to be covered in the panel. So the ones which won't be, I will be just asking those. So the first question is, I think you've already covered, that is how good will be the newborn screening in SMA diagnosis and the treatment advantage of it?
So you must be covering it in your, no. So newborn screening as of now, I don't know. People might differ. It's not, SMA is not the real candidate for newborn screening at present. It should be congenital hypothyroidism, CAH, galactosemia, biotinidase, which are easily treatable in Indian subcontinent. SMA, I will ask for screening the parents, prenatal screening rather than newborn screening, because once you diagnose SMA in the newborn, will you be able to provide a therapy in our country? So it will act as probably more litigations, more trouble for the parents rather than real good. So as per Younger's criteria, if you cannot provide a correct therapy, we should not do newborn screening, but definitely with time, newborn screening will be part of our SMA newborn screening will part of the whole newborn screening.
So prevention still better than cure for SMA till for the present scenario. Saurabh sir, will you like to comment about this newborn screening?
Yes.
No, I think
So
he's
to
right.
a large extent, I agree with Dr. Kaushik that in our country, economically and financially, we are not ready to provide therapy for everybody. So at this stage, we really are not ready for newborn screening. But in the West, yes, newborn screening is useful because they are able to provide treatments. And the gene, so basically the SMA is a condition where you keep losing anterior horn cells with time. So if you detect them early and are able to provide treatment early, you are able to get much better results as compared to what is currently happening, unfortunately, in our country, where children start receiving treatment when they are already in a bad shape, and you end up kind of increasing the load of disability rather than helping anyone.
Right. Okay, thank you, sir. We have one last question which we'll take, Kaushik sir, and then maybe we can move on. What is SMA-RD and what is the genetics of this?
I have already discussed this. It is SMA respiratory disease. It's a single gene disorder. It's an autosomal recessive condition. It mimics SMA. I have never seen one. I have never seen one, but definitely it's a differential diagnosis, and we should keep in mind, like when we don't find the common SMA or common disorders, there are some pointers to other common disorders like Zellweger. You can find chondrodysplasia punctata. For Prader-Willi, you have the very typical presentation, and you can do a microdeletion study for Prader-Willi. For this, we have to do a single gene disorder study by sequencing.
Thank you. Thank you so much, sir. Rest of the questions we can take, I think, alongside the panel.
Thank you, Dr. Veronica, for taking over that session so well. And thank you, Dr. Kaushik, for such an extensive and informative session. Moving on to the panel discussion. Firstly, I would like to introduce our esteemed moderator for today's panel discussion, Dr. Veronica Arora. Reintroducing her for all the audience who have joined a little later in the session. Dr. Veronica is a consultant and assistant professor of medical genetics at the Institute of Medical Genetics and Genomics in Sant Gangaram Hospital, New Delhi. She is certified from the European College of Medical Genetics. She is an executive member for SFM Delhi chapter, an executive member at ISPAT, again, executive member at the ISOPARB in Delhi. She's part of the medical advisory board at the Myositis Society of India. She has been awarded the Young Achiever Award by the Association of Nationally Accredited Board, NBEMS. She has authored over 63 publications in peer-reviewed journals. Her areas of interest include fetal malformations, RPL, autism, and fetal skeletal dysplasias. Her educational background include MBBS, MD, and DNB in OBGYN. She's also done her Dr. NB in medical genetics, where she has been a gold medalist. Welcoming you again, Dr. Veronica. Now, I would like to introduce our panelists for today's panel discussion, starting with Dr. Narendra Malhotra. Dr. Narendra Malhotra is the Managing Director of Global Rainbow Healthcare, Ujjala Cygnus Rainbow Hospital. He is the Director of ART Rainbow IVF, Director at the Foxy Smriti Manyata CSE. His experience includes, he has been the Vice President of the Society of Ovarian Rejuvenation, Director of International Relations at SAFOG, National Director of Ian Donald School of USG, Professor Sarajevo School of Science and Technology, and Dubrovnik International University from Croatia. In the past, he's been the Vice President of SAFOG and WAPM, President of ISAR, ISPAT, IFUMB, FOXY, AOGS, ICM, Dean at ICMU, and INSARG. He is the founder editor for SAFOG Journal. He is the member of FIGO Guidelines Committee from 2014 to 2017. He is the chairman for Smriti NGO, New Level of Care. He has authored over 125 papers and 300 chapters, over 500 presented papers. He has given over 1,000 guest lectures in India and abroad. He has been the editor for 59 books, many chapters on the editorial board of many journals. He is the revising editor of Donald Obstetric Manual, revising editor of Foxy's Ultrasound in Obstetrics and Gynecology. His educational background includes MD, FIAJAGO, FICMU, FICOG, FICMCH, FRCOG, FICS, FMAS, and AFIAPM. I am glad I got through all of them without any mistake. Okay, next, I'm moving on to Dr. Ratna Puri. She is the professor in genetics and chairperson at the Institute of Medical Genetics and Genomics at Sir Gangaram Hospital, New Delhi. Her experience includes she has been awarded Dr. I.C. Verma Outstanding Researcher Award in 2019, the Dharamveer Award of Excellence in 2010, and the Young Investigators Award in Tokyo, Japan in 2006. Her memberships include Undiagnosed Disease Network International of NIH in USA, Diagnostic Scientific Committee, International Rare Diseases Research Consortium, panel experts of WHO Collective Global Network for Rare Disease International. Her ongoing research projects include Indian Undiagnosed Diseases Program, Established Registry for Rare and Potentially Treatable Genetic Disorders, Artificial Intelligence in Genomic Profiling and Diagnostic Yield, Molecular Characterization of Lethal Skeletal Dysplasias, Sequential Evaluation of Patients with Muscular Dystrophies by Deep Phenotyping and Molecular Studies. She has authored over 140 publications. Her educational background includes MD Pediatrics in AFMC, DM in Medical Genetics from SGPGI, Lucknow. Good evening, ma'am. Thank you for joining us. Our next panelist happens to be Dr. Anurag Agarwal. He is the senior resident at MAMC and LNJP Hospital in Delhi. He is the professor at the Department of Pediatrics in Maulana Azad Medical College and associated Lok Nayak Hospital, GB Pant Hospital. His experience includes he is the founder secretary of a consortium against rabies. He is the national trainer and resource faculty for infant and young child feeding and counseling, neonatal resuscitation program, IMNCI, facility-based newborn care, asthma, IAP, and ALS. He has authored chapters in books and conducted conferences, CMEs, and workshops as the organizing secretary and organizing chairman of PCNI, NDPC, and CARSONS. He has participated as faculty in numerous conferences like Pedicon, Neocon, PCNI, APC, RICon, and CARSONS. He is the reviewer for Indian Pediatrics and Indian Journal of Child Health. He is the sub-investigator and principal investigator for many national and international trials like Inspire, Prevail, in collaboration with INCLEN and Johns Hopkins University, and ongoing hexavalent vaccine and monoclonal antibody trials. He is the secretary at IMA Rohini 2000. He was the secretary of IMA Rohini in 2013, secretary of IAP Delhi in 2016, secretary of IAP North Delhi from 2015 to 16, and the president of IAP North Delhi in 2018. His education background includes MBBS and MD in pediatrics. Good evening, sir. Thank you for joining us. Our next panelist is Dr. Vijay Chandru. Dr. Vijay Chandru is the professor. He has done his PhD from MIT. He is the co-founder and director of Strand Life Sciences. He is the honorary director at Chet India and Opford Foundation. His experience includes he has served on the Faculty of Engineering at Purdue University and at IISc. He is currently the visiting scientist at Harvard School of Public Health, NCBS, and Center for Brain Research. He is an elected fellow of both the Indian Academy of Sciences and Engineering, INEE. He is a technology pioneer of World Economic Forum since 2006. Dr. Chandru has served on the Future of Healthcare Committee at WEF from 2014 to 16. In his work at Chet India and Opford Foundation, Professor Chandru has been committed to orphan disease outreach with scalable platforms towards the vision of no disease orphan by 2030. He was a National Distinguished Technologist of the Indian National Academy of Engineering, an adjunct professor in Biosystem Science and Engineering, and executive advisor to the New Art Park. His educational background includes electrical engineering at BITS Pilani and operational research at UCLA and MIT. Good evening, sir. Thank you for joining us today. Our next panelist is Dr. Anup Thakur. He is the senior consultant in pediatric neonatologist at Sir Gangaram Hospital, New Delhi. He is the associate professor at GRIP MER. Experience, he is a qualitative initiative graduate from IHI, Massachusetts, CEURF, Critical and Lung Ultrasound, Hospital Ambroise Paré from Paris. He has received the gold medal in MBBS and MD. He is the reviewer at Biotechnology Industry Research Assistance Council India and other national and international journals, including Frontiers and Indian Pediatrics. He is the trainer for advanced echocardiography and USG, advanced NRP and neonatal simulation. He has authored over 82 publications and is the editor of 2 books on quality improvement and NICU care. His educational background includes MD in pediatrics and DMB in neonatology. Good evening, sir. Thank you for joining us. Our final panelist is Dr. Saurabh Chopra. He is the senior consultant in pediatric neurology. He is practicing at Max Hospital in Delhi, NCR. He is the director at Max Hospital. He is in the tuberous sclerosis clinic. His experience includes the academic experience is the assistant professor at MP Shah Medical College, Jamnagar, and associate professor at Subarti Medical College in Meerut. His clinical experience includes he has worked in some of the leading hospitals in UK and Australia, as well as Delhi NCR, including Fortis Hospital in Noida, BLK Hospital in Delhi, and Max Hospital in Delhi NCR. His educational background includes MBBS and MD in pediatrics, pediatric neurology fellowship, Bill Marshall Fellow in pediatric neurology and complex epilepsy, and Rats of Tuberculosis Epilepsy Fellowship from RCH Melbourne. A very good evening, Dr. Saurabh. Thank you for joining us today. Again, I would like to inform if there is any question from the audience, please leave it in the Q&A section. And now I would like to request Dr. Veronica to take over the panel discussion.
Is my slide visible?
Yes, ma'am.
Welcome all esteemed panelists to this discussion today. We'll be discussing 2 cases, and this is the first one. As we can see, this is a pedigree chart, and we can see that there is consanguinity here. So our proband, or the affected child, is a 2-year-old boy, second in birth order, who's born to 3rd degree consanguineous marriage. And the parents brought the baby to us in view of motor developmental delay and hypotonia. So the first question is to Dr. Narendra Malhotra, sir, that how does consanguinity give us a clue in diagnosis of genetic disorders or other disorders? And what is the role of obstetrician in picking up these disorders early and early referral?
So thank you, Veronica, for inviting me here to this great meeting. Lovely lecture. We've just heard all about this. We know that these disorders are autosomal recessive. So to draw a pedigree chart is the most important thing which an obstetrician and gynecologist should do for every pregnancy. I would say once a pregnant patient comes, draw a chart. And even if it is normal, just get in the habit of drawing a male-female consanguineous, because once you know how to draw a chart, you will pick up consanguinity. And we know that consanguinity will, because of autosomal recessive, will bring this to that next generation, and one generation and it's equal, the male and the female could be equally affected. So to draw this chart is the first thing which an obstetrician should do. We know it is autosomal recessive, so that's because of that. And the second thing which will give us a clue, which should have given a clue in the antenatal period, is that the patient would have complained of repeatedly less fetal movements. And that should have given us a clue that there could be some skeletal muscular atrophy or spinal muscular atrophy or some disease. And then when you do an ultrasound, you look at the movements, and so if it's sluggish, not moving, then you could think of these things and probably lead to a suspicion of such a thing.
Thank you so much, sir. So probably when there are reduced fetal movements, obstetricians should get alerted of a neuromuscular disorder. So next question is to Saurabh sir, who is our pediatric neurologist. So what are the differential diagnoses in such a child with hypotonia and delayed motor milestones?
So I think as we have all learned from our MBBS days, hypotonia can be due to the CNS, yeah, as well as it can be due to the peripheral nervous system. So in fact, central nervous system causes of hypotonia are actually relatively more common. But in those cases, we usually have other clues which help us, like a patient with HI will be quite hypotonic, but there'll be a clear history of perinatal asphyxia. Children with Down syndrome and other chromosomal anomalies will be relatively easy to pick up. Except maybe a young baby with Prader-Willi syndrome. Those are cases where it may not be that simple to pick up, and they can sometimes mimic almost like a neuromuscular disorder. Among the neuromuscular disorders coming in younger age groups, I think SMA is definitely the most common that we see. And now with experience, I think most pediatric neurologists are able to pick up clinically SMAs and directly send genetic testing. So differential diagnosis among the other peripheral nervous system disorder is quite wide. I don't think it will be very worthwhile to go into the details of that. There are lots of myopathies and muscular dystrophies and even congenital myasthenia that can come up as a floppy infant.
Thank you, sir. So basically for pediatrician, just to differentiate between a central and a peripheral cause, according to you, is most important. Yes. So next question is to Dr. Anurag, sir, that when do you suspect SMA in these children?
Thank you for having me with such a learned panel. I believe I'm the only pediatrician here. And
we are all
we are all pediatricians.
Lots of
So
us.
most of all are super specialists, geneticists and gynecologists with a lot of degrees from various fields. But I'll tell you what we people do, because we keep handling general pediatric practice. So we teach our residents to do some simple things. That a child who's presenting to us with a hypotonia, that is a floppy child, and presenting with recurrent respiratory infections like multiple episodes of bronchiolitis, or a child coming to us with weakness, generalized weakness, and the reflexes are absent, or the child is regressing on milestones. He is not able to sit, but is alert, is looking at you alertly, but is not gaining weight, not thriving, is hypotonic, is floppy, slipping through your hands. A simple way to look at it: you hold the child and he slips through your hands. Maybe you can think of SMA. Earlier, when we were PGs, we used to call it Wernicke-Hoffman. I think Dr. Mandal mentioned it. So it came back, running back to me. And nowadays we call it SMA. So various grades are there. Yes, a newborn presenting with respiratory failure and infections and needing some kind of respiratory support, not responding. There is no evidence of sepsis. That is the variety we call SMA type 0. And then the variety which presents to us before 6 months of age, around 6 months of age or before 6 months of age, when there is loss of head control, there are some amount of contractures or minimal facial weakness, then SMA type 1, and the older babies SMA type 2, wherein there is some amount of motor developmental delay or absent reflexes, some proximal muscle weakness, and then there may be some postural tremors also. So this is the way we usually suspect SMAs, and then refer them to genetics for further opinion. Thank you.
Thank you so much, sir, for an elaborate explanation. So next question is to Dr. Saurabh. What investigation would you like to do, sir, in view of the differential diagnosis that you discussed? And elaborate, sir, please, on the role of CPK and NCV in these diagnoses. Sir, we cannot hear you, sir.
Yeah, as I just said, that most cases of SMA are pretty straightforward to diagnose. If you have a child who has no reflexes, is quite floppy, and has tongue fasciculations coming up, your differential diagnosis is very narrow. And in those cases, sending maybe nerve conduction testing is not very useful because it actually at this point in time costs more than a genetic test for SMA. CPK is definitely useful. It is a cheap test and helps us differentiate between, say, some of the congenital muscular dystrophies, which will come up with very high CPK levels. Whereas SMA, you will have either normal or just slightly raised CPK. NCV is also not extremely easy in a very, very young baby. Very few centers have the expertise to do NCV in a, say, a newborn or just a 1 or 2 month old baby. But yes, in older babies, you can do it fairly easily. In NCV, it is very useful to differentiate between the various differential diagnoses. So if you have, say, like a congenital myasthenia, you will have a decremental potential. If you do repetitive stimulation, you will have a decreasing potential. Some centers are also able to do single fiber EMGs, which is useful to diagnose myasthenia. In SMA, usually it is just the motor nerves that are affected. The sensory nerves are completely normal. And that too, because it is the nerve fibers that are reduced, it is only the amplitude that is affected. The conduction velocities will usually be more or less preserved. The other basic investigations, as you are elaborating, one should not miss out on something as simple as a congenital hypothyroidism. So that should be obviously considered. And if you have a doubt clinically, if you have a clinical doubt, you're getting a few reflexes here and there, you're not getting any fasciculations. In those cases, doing a NCV and a EMG is very useful because there you will be able to differentiate whether it's a anterior horn being affected, it is the muscle being affected, or it's a rare form of neuropathy that is coming up. So in those cases, when you have clinical doubt, nerve conduction and EMG can be quite useful.
Thank you, sir. Ratna ma'am, will you like to add anything to NCV or EMG first or genetic test first?
No, not at. I mean, we also don't do NCV and EMGs in a newborn. Okay, and the only one thing I'd like to add is CPK would also help for infantile Pompe, but of course there's cardiomyopathy. There's a big heart there. We don't have IOPD in the absence of cardiomyopathy. So I think he's covered everything very well.
Yeah, among the metabolic myopathies, in fact, some of the really good electrophysiologists are able to differentiate that too on EMG, whether it's a metabolic myopathy versus a genetic myopathy, the other forms of sort of muscular dystrophy. So there are some who are really good.
But now, I think the tests have become reasonable. They've become accessible.
Yes.
So that really helps.
Yes.
That really helps.
Yes.
Thank you. Thank you, ma'am. Thank you, sir. So the next question is to Ratna ma'am, that what is the confirmatory test in the situation where we have a mildly elevated CPK, hypertonia, absent reflexes, and what would you like to do in this situation?
So when we think of SMA, there is a very simple PCR-based test which tells us whether there is a homozygous deletion, which means that we know. So I think first, because I saw some questions related to chromosomes, SMA occurs because of a mutation in a gene. Both copies of the gene are not functional. And it is the same mutation, which is a deletion of the SMN1 gene. And in both copies, the gene has to be deleted for the child to have the disease. A homozygous deletion, as we refer to it, because it's the same mutation in both copies, the homozygous deletion can be picked up by a simple PCR-based test. So if clinically you are sure, you may just do that. Or maybe you're not sure. I think that is a situation where we could do it. But of course, the gold standard is this other test, which is also a DNA-based test called MLPA. That Dr. had alluded very well in his presentation. The advantage of the MLPA over that simple based test is that it also tells us the SMN2 copy number. And that is very important today. One, for telling us what could the phenotype be, but of course that's a generalization, and also very important for therapeutics today. So as a, essentially everybody just does the MLPA today. And so if you have SMA, there is, as it's shown here, the SMN1 gene copy number is 0 because we are, you're testing for exon 7. So it is the exon 7 and plus minus exon 8 has 0 copies. And the SMN2 copy number is either 2 or 3 or 4. So this is what this test can tell. You don't do exome sequencing.
Thank you, ma'am. So, ma'am, in this case, the SMN copy number was 0 and the SMN1 was 0 and SMN2 was 2. So how do we interpret this, and what are
this
the
confirms
things
that
we
the
can...
child has spinal muscular atrophy, and most likely it is type 1. But really now type 1, type 2, type 3 are functional. So we say that, type 2 are sitters, they are walkers, and type 1 are non-sitters. But of course, the copy number, if it's type 1, it's usually 2 copy numbers in most. But it can also be any other way. But this is the common thing that we find.
Thank you, ma'am. So I've written type 2 because the child was a sitter. So this means a lot of modifying factors that deserve mention as well. So one question I think we have a lot of times in the chat is that if we have hypotonia and muscular dystrophy, should we do DMT, MLPA first, or whole exome sequencing, or SMA?
DMD will not present in the neonatal period. That's one thing that's important. So it really depends upon the phenotype. When has your child presented? What is the phenotype? And in DMD, always the CPK is very, very high. It's not like 1,000 or 3,000. It's in tens of thousands. So they are two different things.
Can I also speak once? Kaushik here.
Yes, please.
Yes, sir, please.
Probably it is congenital muscular dystrophy and not Duchenne muscular dystrophy, which comes as a more common differential of SMA. Congenital muscular dystrophy is a different disorder than really DMD. Probably that is what people are confused.
Okay. Thank you, sir. So in this period at 2 years of age, the disorder to be considered is a congenital muscular dystrophy, SMA, or the others we just mentioned, and this is not a typical age of presentation of DMD. So ma'am, another question is that can SMA still occur if the MLPA is normal?
So yes, there are, Dr. Kaushik had shown us, in about 2 to 4% cases. In one copy, there is a heterozygous. That means only one copy is deleted. Exon 7 is deleted. Whereas on the other side, there is a point change. But this is a rare situation. I've only seen one patient till now. I don't know about Dr. Saurabh and Dr. Kaushik, but I think it's really very uncommon.
So we have another question, is the same question with ma'am just answered. Is there any possibility of inheriting the condition with heterozygous deletion in either SMA 1 or 2? So ma'am, they also need clarity about SMN1 and SMN2.
So the active gene is the SMN1 gene. And I think that's important to understand. You can have a deletion of the SMN2 gene. As long as the SMN1 gene is present, you will not have a disease phenotype.
Thank you, ma'am. So now we move on to a question which is open for everyone to answer, and everyone can share their experience that once SMA is confirmed, what are the things that should be told to the family? Sorry, the F is missing. We can start with Malhotra, sir.
So, you see, it is very important to counsel the family. Now, this is a disease which has treatment, but it is, it's like Down syndrome babies. Whether there is a treatment, whether you want to deliver these or bring them into a world or not, who live to adulthood and a big burden on the family, society. So maybe it's not a scientific answer. It's more of an emotional answer, but that's how we started doing down screening and all, started offering them termination. So maybe if we can diagnose early and counsel them that you might have a baby which will be affected like this, and once we get a definite diagnosis by CVS or amnio, maybe a termination could be offered to them. Otherwise, if the baby is born, then of course we need to treat to the best and make the life happy for the baby and for the couple also.
Absolutely. Thank you, sir. Saurabh sir, will you like to comment?
Yes, so SMA, the family counseling may vary according to the type. So children with type 2 and type 3 are going to have a reasonably long life. So we really need to take care of these children and giving them a proper understanding of how the disease progresses and how we can change its course even with simple measures like respiratory supports and nutritional supports is really very important. And unfortunately, the knowledge and understanding is still lacking among most patients. There is a huge push about genetic treatments which are out of reach for most of the patients. And many times I've seen that, in fact, right now, just in between the seminar, I had a long discussion with my pulmonologist about a patient who is SMA1 already in a rather bad state, and the family has kind of arranged for so much money and they are pushing for genetic treatment, and we are really not ethically sure of what to do. So it's become a very, very complex situation. Improving general care, I think, is much more important than pushing for genetic treatments, and making the families understand why it is important, I think, is the most important thing we can do to change care. Thank you.
Sir, Anurag sir, will you like?
Yeah, applicable to all chronic illnesses, you have to break the news in a sensitive manner. You know, when we are young, we are very happy to announce your child is suffering from this disease and we have diagnosed it and nothing can be done, and all those kinds of statements. So there are certain sets of counseling skills which have to be used to break the news, then to support the family. As sir rightly said, that genetic therapy is extremely costly and available to a select few, and which will also help only if given to a very young age, who are able to afford it and then are in a situation to recover from the disease. So what needs to be done is support of the family, emotional support of the family, psychological support of the family. See, once you tell the family कि आपके बच्चे को ये बीमारी है, the first reaction will be feeling of guilt, then blaming. Before that, there'll be denial कि नहीं नहीं गलत बोल रहे हैं. Then there will be guilt. We'll blame each other कि ऐसा हुआ था, wife की गलती है, husband की गलती है, और दादी की गलती है. All kinds of stories. So that is the way human mindset works. Then finally comes acceptance, and then they will go in for therapy once they are able to accept the disease and their socio-economic and financial status is such. Otherwise, in a country like India, wherein both the husband and wife are working to earn their livelihood, it becomes so difficult to take care of a child who is chronically ill, and especially with conditions like SMA. It is really, really difficult for them. So they'll need all kinds of possible support, emotional, social, family support, and everything. This can even lead to marital discord and even lead to divorces. So we have to be very careful while counseling these parents and provide them as much support as possible, being clinicians. Thank you.
Thank you, sir. We'll come to treatment with Ratna ma'am in the next questions. Just before that, I'd like Dr. Vijay Chandru sir to give his comments upon the trials and the work his NGO is doing.
Oh, thank you. So as you heard in the introduction, I, of course, have also been involved in setting up, the Strand Life Sciences. And so for about 10 years now, have been very much involved with patients who we help to resolve, some of these diagnostic odysseys on various rare diseases. And so after I stepped out of corporate sort of executive life about 7-8 years ago, I've been working with foundations. CHET India is our foundation that looks broadly at rare diseases. Our outreach is we are careful not to give clinical advice. We essentially try to be supportive to the families, direct them to clinical resources that are local to them, and provide knowledge and information. For example, CHET India carries a series of videos on spinal muscular atrophy delivered by M. Pradeep Kumar. And we've actually also made clips of them based on the topics and have put them out in social media so that there's general public access and awareness builds up. But again, I think no clinical advice. It's always just pointing them to the right treatments. I just want to point out that 10 years ago when we, several of us around the country in different companies, different labs, set up sort of sequencing. The hope was that, like Moore's law, the cost of genome sequencing would come down rapidly, and that at some point it would become sort of democratized or accessible or available at a certain price point. I think we are there, and we're very close to it right now. I think today, doing a whole exome at a high depth of maybe 100x or more is possible at well under $100. So maybe 7,000-8,000 rupees. It's possible to do that, and then help essentially the country towards adapting to the fact that we can do prenatal screening. I think I agree that perhaps newborn screening is not the right stage right now for the country, but prenatal screening, certainly using genomics is something that we should think about. I just want to reveal here that because of my access to all these technologies, I did my own genome, obviously, and I because of the high depth sequencing now, I found that I have a missing SMN1 gene. So I am, I think Dr. Kaushik Mandal had said 1 in 71 in India are carriers. I'm one of those, right? And of course, I didn't know it at a prenatal stage. I have a daughter who's a pediatric surgeon. She's over 40 now, and I have a granddaughter who's 9 years old. And we'll certainly, I think when she reaches adulthood, have her screen or suggest to her that she should screen. So I think these, we are entering into a new era that I think. Now, of course, when it was found through the genome analysis, in my case, we did go to an MLPA for confirmation. So I think no question that MLPA is the gold standard, but I think sequencing is also becoming more accurate and I think affordable, most importantly, and I think so. Bringing all this together is actually what we can do through these foundations. I think it's the bringing down the costs of therapeutics and so on is another activity that foundations can do, but that requires a very different level of resources and capabilities. Although I think we will see, antisense oligotherapies. We already have some startups in Bangalore doing very interesting work. I also founded a CRISPR group that is working on gene editing. So I think there are many activities that one can push in this direction. But primarily, what the foundations provide is access, helplines, just someone to talk to, point them in the right directions. I think that's really been our effort largely. Right. Thank you.
Thank you. Thank you so much, sir, for an elaborate description of your foundation. So let's quickly move to the next question as we are now quite behind time. So question to Dr. Anurag, sir, is just briefly explain to us that what sort of follow-up do you recommend in these children, and how often do you call them for a consult after the diagnosis?
Yeah, so just in brief, we have to look at the nutritional status of the child. We have to plot them on a standard growth chart and look at their growth. Are they growing adequately? If not, we will have to look at their diet plan. What is happening? Are they suffering from constipation? Are they able to take enough? Are they having GERD? Because they are prone to GERD, they are prone to recurrent respiratory infections. So all this has to be managed. The saturations have to be kept a watch on. Their FE, forced vital capacity, FVC, has to be looked at, because if the FVC is low, there is bright chance that they'll go into respiratory failure during sleep or during infections also. Airway clearance is important. They have to be taught how to percuss their chest to bring out mucus. Other than that, if they have some amount of deformities, those also have to be taken care of. Their gross motor and fine motor skills have to be improved, have to be supported by physiotherapy. So a lot of things have to be done. And of course, the final family support, the support for resources and emotional support, everything has to be provided to these children. So in a nutshell, they need multidisciplinary approach. It is not the job of a single person to support this family. The best way would be to have a clinic wherein all these specialists are available to manage these children. Thank you.
Thank you, sir. A question related to this very question was that what nutritional support should be given and to whom should the patient be referred if there is swallowing or nutritional problems?
See, you will need a specialized center wherein such kids can be managed, because you will have to take the services of a nutritional rehabilitation center, NRC, with the thought process in mind that these children are at a risk of aspiration and constipation. So ultimately, a pediatrician along with a good dietitian who is trained in giving diets to these children, that is pediatric population. So like, for example, we have such a dietitian who's managing pediatric population. So these kind of centers you will have to refer to. Maybe Gangaram has one. And other than that, there is nothing special that you will need other than monitoring and preparing their diet charts and seeing the amount of weight gain they are having regularly. And of course, building up their multivitamin and micronutrient deficiencies.
All right. Thank you so much, sir. Ma'am, Ratna ma'am, will you like to add something also?
No, I think it's been covered, and I think as physicians, and it doesn't matter what specialty, if either of us come in contact with a child, it has to start with breaking the news. And I think we should not forget that. They need family support, and then of course multidisciplinary care. And that is what has to be stressed on them, because that takes them a long way. And so, while we talk about definitive therapies, I would never talk about definitive therapy if the family is not motivated. We are lucky we don't have very, very nuclear families in a lot of places, because you need a lot of family support. It's very difficult for the lady if she's not working to manage alone, and if she's working, it's very difficult, because a lot of our patients say, "Hum to ghar pe hi kar dete," and then I have to tell them कि आप physiotherapist तो हो नहीं, तो आप सीखो, but you have to follow up, because these things are really relevant. The therapies will not work in the absence of appropriate supportive care in all specia. There are muscles everywhere. So you have to look after the lungs, you have to look after the feeding and the nutrition. Some of these children, NG tubes, pegs for that initial period, otherwise they keep getting aspirations because of poor swallow, and they keep getting sick, so it becomes a vicious cycle. Type 1s have...
Ma'am, what is your ideal multidisciplinary team that you would, ma'am, what is
Yes,
your
so here,
ideal
so there has to be
multidisciplinary
a
team that you
central,
would like?
yeah. So there has to be a central person who coordinates everything. It can be different in different hospitals. There would be a pediatrician, there would be a pediatric neurologist, a geneticist, a gastrophysician, a nutrition, a orthopedic, a spine. I'm not sure whether I've missed anything, but this is the whole gamut, because they are well known to have hip dysplasia, so you need orthopedic help there. And of course, they have a lot of, and a pulmonologist. I'm sorry if I forgot that. So this is the entire thing. And when there is pregnancy, then of course you need an obstetrician or a fetal medicine person and a laboratory to do the prenatal diagnosis after making sure we have a proper diagnosis in the affected child or carrier screening in the parents. So that would be your entire team. So it's a tall order, but I don't think it's difficult. They are present in most hospitals. In all hospitals, I think, at least in the tertiary care hospitals, it's just bringing everybody together on board. That's all that's required.
Thank you so much, ma'am. Now, I would like Dr. Saurabh also to share his experience with the multidisciplinary approach.
Yes, so I think ma'am has already covered most of the things. It is just a question of being motivated and motivating the family, because very few of our patients actually go up and end up having pegs and fundoplications and having spinal surgeries or wearing a spinal brace to prevent spinal deformities, which if you go to the West, almost every second patient is going through those things. So it is just about motivating ourselves and then motivating the patients to get things through and keeping the whole team motivated.
All right. Thank you everyone. So the final and a very exciting topic of the treatments that have been available for SMA and specifically for this child that we were discussing, and the child is 2 years old. So we'll like Dr. Ratna ma'am to elaborate on the available therapies and which therapy would you think would be appropriate for this child, this family.
So spinal muscular atrophy is one of those very, very rare disorders which has 3 disease-modifying therapies. And so the first one that was approved in 2016 is Spinraza, the one you see right at the bottom, that is nusinersen. And this is for given intrathecally for all types of SMA. The age is no bar. So it has a loading dose of 4 doses, and then it's given 3 times a year, once every quarter, and it is intrathecal. The second one, which was then approved, was the gene therapy, which was Zolgensma on a Mojine abiparvovac Zio. And this is a one-time infusion, which is given intravenously. And this is approved for children up to 2 years of age and for type 1, 2, 3 for all types of SMA. What is important is that for giving the gene therapy, the SMN2 copy number is not important because you're replacing the gene. All we have to see is that the vector that it's introduced in, the antibodies, because it's an AAV9 vector and adeno-associated virus infections are not so uncommon. So we do have a couple of patients when we test the antibodies, they are antibody positive, and to them you cannot administer the gene therapy. Whereas Risdiplam and Spinraza, the third drug, which is the oral drug, is Risdiplam, and that was the last to be approved in 2020. And that is the only drug that is also DCGI approved in India in 2020. Now, both these drugs are dependent upon the SMN2 copy number because their mechanism of action is, so SMN1 is not there. So they enhance the protein formation by the SMN2 gene. And so therefore they have to be present for the drug to act. And it is that SMN2 gene, which was actually not acting because of certain changes in the gene, now becomes active and produces the SMN protein. So they are lifelong therapies. Risdiplam and Spinraza have to be given repeatedly. Risdiplam is oral to be given every day, and Zolgensma is intravenous. They've gone through a large number of trials. I'm not going to go through them. Of course, they have their advantages, they have their limitations, and I'm not sure whether everybody caught on to it, but a very, very important point that Dr. Saurabh Chopra noted when he was talking about these disease-modifying drugs was the earlier you start the therapy, the better are the outcomes. And there are some things it's not going to impact. If you already have restrictive lung disease or you have scoliosis, it's not going to impact that at all. So therefore, younger children who don't have the long-term complications that come up with time would respond much, much better than children who, have a lot of complications of therapy. Now, there's a trial which is going on for intrathecal gene therapy, and that's also a one-time given intrathecally. We don't have the results as yet. It's ongoing.
Thank you, ma'am. So we are in exciting times of therapies for a lot of genetic disorders. And so finally, as we spoke that these therapies are still expensive and out of reach for a lot of people. I don't think Malhotra sir is here. So basically the question was, what will we advise the couple for planning a next pregnancy? So we will provide genetic counseling as that has been discussed. It is an autosomal recessive disorder. So the chance of recurrence would be 25%. The ideal thing would be to do a chorionic villus sampling at 11 weeks of pregnancy and do the same test as was done in the index child. If we don't have the index child, then we can do the carrier of the parents and do the SMA MLPA in the CVS sample. Also, we have an option of IVF with PGT that can be offered. It is not that well established for SMA as yet. So thank you everyone for this
Can I
very
just add
informative
one point here for the obstetricians, Veronica? That because it's a recessive disorder, like we do for beta thalassemia, family at-risk carrier screening. So if I know that I'm a carrier, my siblings have a 50% chance of being carrier, and we should inform the families that they should tell their siblings that testing for carrier testing is indicated and should be done.
All right. Thank you so much, ma'am. Thank you all the panelists for your inputs. I think Anurag sir has to go, and thank you so much sir for joining us. It's his wife's birthday, so we have to let him go.
Oh, wow.
Happy birthday to her.
He let you
Thank
for
you
so
much.
long.
Thank you so much, and she's going to butcher me as I'm already late. Thank you.
Our
Thank
wishes
you.
to
Thank
her.
you for
I'm sure
having
if
me.
you give our wishes to her, she'll be fine.
Yeah, I think she'll spare me. I'll tell her that everybody has wished her happy birthday. Thank you so much, ma'am. Thank you. Thank you for having me on the panel. It was a learning experience. In fact, my knowledge has been refurbished and I'll be able to teach better. Thank you.
Thank you.
Thank you. Thank you so much. So we will continue with the second case now. So we have a 40-day-old neonate who was brought to the nursery in view of tachypnea and acute respiratory distress. He was cynosed and required intubation and ventilation. This was a non-consanguineous marriage. There was no family history of a similar genetic disorder. The examination revealed severe hypotonia and absent reflexes. So so sir is not here. So we will just move on to the next question to Dr. Anup sir, who's a senior neonatologist at Gangaram Hospital. So what are the physical examination findings that would point towards an anterior cell involvement, and what, according to you, are the pointers in the NICU towards SMA as compared to other differentials?
Well, thank you, Dr. Veronica, for the opportunity. And I feel like I have been sent on a spacecraft without being trained in the docking maneuvers, and my mind is all getting dazzled by the enlightened speakers. Well, our approach is always to go conventional. It is not only SMA we think about. So first of all, we think whether the disorder which we are seeing is central or peripheral. So for central hypotonia, so the features are there could be history of seizure. There will be some degree of encephalopathy, feeding difficulties. Then the tendon reflexes will be preserved or they could be brisk. And then in those cases, there is more of a axial hypotonia. So there is more like a central disorders. Uh, we have to rule out the common conditions like HIE, brain malformations. If there are signs of dysmorphism, we need to look for chromosomal abnormalities. And we should always rule out common disorders like sepsis, meningitis, hypothyroidism. So that should be an approach as a clinician always to rule out the common things first. Then if we are suspecting a peripheral disorder, hypotony, we should try to find out where is the lesson. So in anterior horn cell lessons, like in SMA or congenital poliomyelitis, what happens is that you will have hypotonia, there is areflexia, there is no sensory involvement. Usually the extraauricular muscles are preserved, they are normal. And then you can sometimes find fasciculations in newborn babies, but it is difficult. An easy way is to do ECG, and sometimes that can give you a chest wall fasciculation. So that could be a trick sometimes which fellows can pick up. Then if the lesson is at the level of, say, neuromuscular junction, which is myasthenia gravis or botulism, then the involvement is more of the extra ocular muscles. And there again, the reflexes might be preserved, the sensation is normal. And there again, you may get neuromuscular junction. If you do a EMG, you may see an decremental response in myasthenia gravis and an incremental response in botulism. So that is another type. Third disorder could be at the level of nerves, which is peripheral neuropathy. So here, since the nerve is gone, there'll be absent reflexes, absent sensations. And here again, there could be contractures. In all these disorders, the sensorium is intact. If the lesson is at the level of the muscles, like congenital muscular dystrophy, then you have to examine the mother. They have tented lips, and you do a handshake. They are not able to release the hand. So those findings could be there in the mother. Muscular dystrophy per se doesn't really present in the newborn period. We don't see much of Duchenne or Becker. They present little later on. And there the approach would be to get a CPK and it would be in thousands, as Dr. Ratnapuri was saying. So as clinician, we try to take out which level is affected, the central or...
Okay, we'll move on to the next question, which is for Dr. Saurabh and Dr. Anu. Dr. Saurabh, so you did answer the similar question for a 2-year-old child. Will your approach vary in this case as well? And Dr. Anup, sir, I don't think he is here with us as yet.
Right. So in a very young baby, obviously, some of the other differentials would come into the picture. So as you've rightly put in your slide, one needs to think of a basic metabolic workup as well as your thyroid screening. But besides that, I think the approach will remain more or less similar because rest of the differentials will be quite common. So I think if we are highly suspicious of SMA, then after a CPK, we can directly go for the gene testing. Whereas nerve conductions would be quite challenging in a very, very young baby. And so would be used sparingly because sometimes the babies are sick and even practically kind of transferring them to the electrophysiology lab is a problem. And doing a good electrophysiological test in the NICU is next to impossible, actually. So sometimes there are lots of practical difficulties for which nerve conductions and EMGs may have to be skipped or at least postponed in these cases. Sometimes if you are not suspecting SMA as the first possibility, then doing a more widespread genetic testing might be more useful, like doing next generation sequencing. Thank you.
All right. Thank you, sir. So, so we will do a basic metabolic workup, do a CPK, and then maybe proceed towards testing. And now our next question is to Ratna ma'am, that we did an MLPA test again, which we discussed was the test of choice when we were suspecting SMA. It again shows that it was a homozygous deletion of SMN1 and there were no copies of SMN2. And there was a repeat testing which was done, which showed that there was one copy of SMN2 as well. So, what would these tests indicate, and what are the counseling challenges for such a family?
This is zero copy of SMN1, and therefore it confirms that the child has spinal muscular atrophy. The second thing that it also shows is that the SMN2, there are no SMN2 copies. It is zero copies. Is that what you showed, no? So this is a very rare phenomenon. It's not very common to get this. And so this is a severe phenotype because we do not have SMN2 to ameliorate the absence of the functional copy of SMA. And therefore, this was definitely SMA type 1. And it's also relevant that when we are talking about disease-modifying therapies in this case, the only one that would really work is gene therapy, where you replace the gene. But this is a very severe phenotype, and they would usually have respiratory failure, would need support, and all those things. So you have to start again by counseling the family, and once you've made the diagnosis, sitting them down, talking to them about the disorder, and also talking to them as to how it occurred, how common the carrier frequency is in India, etc., etc.
Right. Thank you, ma'am. So Dr. Akhila is also here as a chairperson, who's also a renowned geneticist. Ma'am, are you here? Okay, so maybe she is not in the discussion at present. So the next question is to Anup sir. Sorry, sir, you were disconnected. So are you here now?
Yes, yes. So India has reached the Chandrayaan, but in Gurgaon, sometimes, electricity can just go off.
So what are the common challenges you face in neonates with SMA type 1, and how do you combat these in your nursery?
See, basically, to survive, you need to breathe and you need to eat. So these are the two major challenges. That one is to provide respiratory support. So SMA type 1 could be severe, requiring intubation and prolonged ventilation. We try to get these babies extubated early and provide some form of non-invasive ventilation, because that's the key so that they can go home, even on home ventilation if possible. So high flow nasal cannula, CPAP, all these machines are now available in India also, even low-cost machine, so they can take care of the child at home. Second job is to provide them with nutrition, and they are usually not able to deglutinate. They are swallowing disorders. They require prolonged tube feeds, and this is actually a tough task to make the family understand that they will need ultimately a PEG tube for prolonged feeding. So we get in touch with our gastroenterologist. We try to counsel the families, show them videos to get a PEG tube done, so that the nutritional aspect becomes easy at home. These are the two challenges basically when we treat these patients in the NICU. Most important is to convince the parents, and important as everybody was discussing, it's more important for pediatricians to be aware that these babies could be managed with multidisciplinary support at home as well.
Okay, thank you so
Veronica, Veronica, I'm so sorry. I think I missed that question. I think you asked a question.
Yes, ma'am. So we were just discussing about this child with SMA type 1 and how this is a progressive genetic disorder. So was asking for your comments and experience on the same.
Yes, the only thing is that we get patients with no child available for answering any of those questions. That is one of the common scenarios for us. With that index child is no more. That's a very common scenario for us with SMA. So that is one thing we always want answers from our geneticists. In our hospital, we have a very good medical genetics department. That is fine, but when you don't have such facility, then how to go about that situation? Your history says that it may be SMA, but the child is not there. I think.
So,
you would do carrier screening for the parents, and they both should be carriers for spinal muscular atrophy. And that indirectly will give you an answer that the child had SMA. Of course, you can never be sure because you haven't confirmed it in the affected child. But if the partners are carriers of a heterozygous deletion in SMA, then we counsel them after that based on what has already been discussed. So for the next pregnancy, I think we've already talked about it. Yeah. So.
Yes, ma'am. We have discussed this, and you also mentioned about the need of cascade screening in especially the first degree relatives. So now our question to Dr. Chandru sir is that you did tell us about your experience and the struggles and hopes of patients with SMA. So we also would like to know, do you assist in them getting treatments in crowdfundings as well?
No, we haven't really worked on the crowdfunding side. I think we, as I mentioned, of course, diagnosis, we can help, we do help. And management in terms of multidisciplinary care, we do advise the patient families that it's important for them to get to multidisciplinary care. But crowdfunding, I think, is a very specialized activity in certain foundations. We have not really gone there. No. Thank you.
All right. So, and in what other ways you think that patients and their families can reach out to your foundation for help and support?
Yeah, the websites are available. There's a wide communication through social media, so most of them can get connected through that. I think we are also developing an elaborate array and library of videos, with a lot of experts like who are here today, speaking about specific disorders and the several dimensions on treatment, support, diagnosis, etc. And we've done it now for about 7 or 8 major disorders, and we'll keep building that library as a resource that patients and their caregivers can access and use to understand better what is the state of the art, right? So, thank you.
Thank
I
you
have
so
a
much,
major
sir.
request for everyone here. The Indian Council of Medical Research has, set up this registry for rare disorders, genetic disorders. And therefore, each one of us, and it's really for SMA, DMD, the metabolic disorders, muscular dystrophies, achondroplasia, the ones that have treatment because they want to understand the burden. The parent groups are trying to build not only for definitive therapy, but also developing the multidisciplinary care. Because when it's okay if you're in Delhi or Gurgaon or Bangalore or Hyderabad, when you talk of patients who come from smaller towns and all, they just don't have access to anything. And therefore, to be able to understand the burden, you could the patient doesn't have to come, just get in touch with any one of us who is within that registry, so we can actually reflect to some extent what the burden of disease is.
Thank you, ma'am, for your message, session, and it was really enlightening. And this, we'll just take some questions, not all, because I think we are out of time. So one very common question, I think, is what is the cost for screening of a couple with SMA? So, of course, it's variable, but if ma'am, would you like to answer?
They'll have to find. So I think it's very variable, and you'll have to find locally where you are based. And I think this is an academic discussion and it's not expensive. I think it's worth any cost to prevent the disease. The cost of managing the burden of the disease is much higher.
So one question for Dr. Anup is that what are the nutritional, I think you did talk about the nutritional challenges, and what is your experience in NG tubes in these children? Do they finally start eating on their own later when they come and follow up?
So basically, for the first few months, we will need a PEG tube or an NG tube, and it's easier to manage with the PEG tube initially because if the feeding tube gets dislodged, it's difficult to manage baby at home. They have to rush to hospitals or nursing home. Sometimes we can train the mothers how to put the NG tube, so that is also feasible. With NG tube, an experience is that the reflux is sometimes more because you are going through the esophagus, you're keeping it patent. Now, again, later on, there's a lot of therapies which is possible in this infants, including the oromotor therapy and physiotherapy, occupational therapies. And some of the kids, they start to improve on their swallowing also. So it's not that it's completely a kind of doom kind of situation. We do see there's a lot of variability in clinical presentations, and some of these kids start to have some improvement in swallowing as well.
Okay,
Just one
thank you.
comment. Just one comment
Yes, sir.
from my side. So nowadays, a lot of recommendations are actually saying that when you end up giving a PEG tube, it should also be accompanied with fundoplication, because children who are bad enough to need a PEG are very likely to have a lot of regurg, which goes undiagnosed. So a lot of centers have now started to do both the things together in patients of SMA, not otherwise, just in patients of SMA.
Okay, sir. Thank you. So there are a lot of pure genetics questions, ma'am. So one is about a silent carrier of SMA.
SMA is an autosomal recessive disorder. So we do expect that both partners will be carriers. But it is also one of those kind of disorders where if one partner is a carrier, in about 2% of cases, there can be a new mutation on the other gene. And therefore, even in the absence of both partners being carriers, you can get it. But I think these are rare situations, very, very rare situations. And it's relevant really to consider it as a recessive disorder where both partners are carriers and offer them testing in the next pregnancy.
Thank you, ma'am. I'd just like to add one thing more, is that if you have one person who's a carrier, another, you do have two copies. In that case also, there could be a 2+0 configuration. And in such a case, maybe a referral for geneticist is relevant. So,
yes, Veronica, Kaushik here. Can
yes,
I
sir.
add? So what
Yes,
you
yes,
have
sir.
told, yes, what you have told is absolutely correct. So in 5% of the carriers, both copies are in the same allele. So and the other allele has no copies. So that is the null allele, and which is when inherited with another carrier copy from a carrier, then that child has SMA. So in 5% of carriers, when you do carrier screening, you won't find that the person is carrier because there are two copies, but both copies are in the same allele. What you told 2+0.
Thank you so much. Thank you so much, sir, for your contribution. So there is a question about a child who's received Zolgensma at the age of 8 months. The diagnosis was made at 8 months, and she was given Zolgensma at 10 months, and she's now 3 years old getting regular therapy. So she's now able to sit. I don't think the type of SMA is mentioned, but maybe mostly it maybe SMA1. What is the prognosis after Zolgensma? Ma'am, Saurabh sir?
Dr. Saurabh, you'd like to take it forward? I think it depends upon how the child is doing as a whole. Dr. Saurabh, you'd like to take it forward? The question was that she's received Zolgensma and at 3 years, she's sitting with support. So what is the prognosis? She was diagnosed at 8 months and received the therapy at 10 months.
Okay. So I think it's heartening to see that a child who was diagnosed at 8 months is sitting. So the prognosis, obviously, it's as in any other classification. So the child has been at least pushed into SMA2. So the prognosis for life is obviously much better. Otherwise, without therapy, it would not have been at this level. So here, but one needs to understand that this child still has muscle weakness. So this child is still at risk of having, say, spinal deformities, and still at risk of having sleep apneas. So the monitoring will have to be continued. And even some children with SMA type 2, that is the sitters, may also end up needing PEG later on in life. So the monitoring for weight gain, growth parameters is very important. And even in this stage, after having receiving definitive treatment, the general care, I think, would be the most important to pull the child through having a good and productive life. Children who are SMA2 have done quite well, as I think Dr. Mandal showed in his presentation. They're writing books, they're doing quite well in life. So, but that is possible only if their general health is kept reasonably preserved.
Thank you, sir. Ma'am, will you like to add your experience with gene therapy?
Yeah, so we have two groups of patients who are receiving gene therapy. One is all types of SMA who receive it in the first 2 years of life intravenous. And I have to say that gene therapy doesn't do any wonders unless we do the proper multidisciplinary care. And I think it's very important to talk to the families about that first, because the multidisciplinary care is lifelong. The gene therapy may be a one time. And then there is also the trial which is going on for intrathecal gene therapy, but we don't know right now. It's a double-blind trial, but we don't know much about it. But we've had patients who received intravenous gene therapy and who've post the gene therapy had a STOMI course. So they really need to be followed up. And most of the STOMI courses are related to respiratory involvement, and therefore good pulmonary physiotherapy and very, very close follow-up with a pulmonologist is required. You cannot do without a multidisciplinary team where you are treating patients with SMA. And I think before giving a drug or before putting up an application, because these are, at least most of ours are through the managed access program, which is a compassionate program by the company, you have to sit the family down and talk to them about the rigors that are required once they receive the therapy. They have to be very motivated. But yes, they do well. They do well. We have a child with SMA type 1 who's standing with support. So it's very encouraging, but a lot of effort goes into it.
Thank you, ma'am. Thank you all panelists for sparing your time today. So I'd just like to summarize what we have just gone through. So we are here for the SMA Awareness Month. I hope all the audience have been much more knowledgeable about SMA. It is an autosomal recessive genetic disorder. It presents with hypotonia, motor developmental delay. You do CPK, which may or may not be mildly elevated. The reflexes will be absent. Fasciculation are quite characteristic of this anterior horn cell involvement. The key to management, as has been said multiple number of times, is multidisciplinary care, and we can prevent recurrence in the coming generations by doing a prenatal diagnosis by CVS at 11 weeks of pregnancy. So we do have new exciting genetic therapies, but the experience with that is modest at best. Thank you so much for having this panel and to ISPAT. And now we will just proceed with the last part of the webinar.
Thank you, Dr. Veronica. I will quickly go to the vote of thanks. On behalf of Strand Life Sciences, I would like to extend my heartfelt gratitude to the ISPAT Society for this collaboration and the opportunity to contribute to your efforts on promoting awareness on rare diseases. We are truly honored to have had the opportunity to bring together a panel of such esteemed experts who have shared their knowledge and expertise on this critical topic. Their valuable insights have shed light on the complexities and challenges faced in managing SMA. My sincere appreciation to the distinguished speakers for their informative sessions and presentations, their in-depth understanding of SMA and expertise, and the dedication to improving the lives of individuals affected by this condition. Extending my greatest gratitude to the panelists who participated in this dynamic session. Your thought-provoking insights and exchange of ideas have provided us with a much deeper understanding of the management challenges that are associated with SMA and the potential solutions that can be explored. Much gratitude to our moderator, Dr. Veronica, who played a vital role in ensuring the dissemination of knowledge and fostering collaboration in the field of prenatal diagnosis and therapy. Finally, thanks to all the participants for your active engagement and interest in this topic, which is crucial in raising awareness and improving the understanding of SMA. Thank you, everyone. Thank you, Dr. Manjeet, Dr. Dani, and Dr. Veronica for your support for this opportunity. And I hope you all learned, and I hope we go with a much bigger responsibility towards the Rare Disease Society. Thank you so much.